This is going to transition what you've seen already, all the advancements in the outpatient setting, as well as progression in research when it comes to stem cells and comes to drugs, and it also comes to devices. But now we're going to talk about the inpatient setting and what do we do when the person is failing in front of you and how do we make things better. So we're going to start talking about cardiogenic shock. As we know, the incidence of cardiogenic shock has now tripled over the last 15 thereabout years, and you can see here that total cardiogenic shock is increasing. The interesting thing about this is that non-acute MI cardiogenic shock is what's really driving this force. And so that, when we talk about it, is more so heart failure than anything else. While acute MI has somewhat leveled off, it's really the heart failure that's taking shape. This was in the in the CARD shock study. Those who developed chronic heart failure were found to develop cardiogenic shock, those 11% of those patients. So it is very significant. So greater proportion now we see is 70% of patients with heart failure and now 30% of patients with acute MI. So what is the presentation of these patients? Back in 2013, this was published in New England Journal of Medicine, and at that time, it was believed to be a patient who was hypotensive with hypoperfusion. So you'll see here when you look at the hemodynamics and you look at the vital signs that you go ahead and you have a drop in blood pressure, whether it's a systolic dropping or the MAP dropping or a relative drop by at least 30 millimeters of mercury below what they had, and pressors are required. Hemodynamically speaking, it's the cardiac index dropping below 2.2, as we know. However, some definitions go through this with a cardiac index of less than 1.8 or less than 2.2 with support, or excuse me, less than 2 with support. And then your wedge being high, indicating high volume status. And of course, now looking into the right versus the left volume status, and of course, right heart failure and cardiac power output. But recently, and actually today is Saturday, so Wednesday, this was recently published, the update of the SKY guidelines and visual of what now we see as shock. And there is a gradation from A to E. And I'll briefly touch on this slide because in the next slide I think it's a little bit more concise for you, but A is for patients that are at risk. And so everything is mostly normal, or what is appearing normal, but then now we go over to B and you're saying, okay, now they're a little bit hypotensive, or they're a little bit tachycardic, but they're not hypoperfusing. And so you still see normal labs, you still see normal lactate, and you still see normal hemodynamics. What about when we get to stage C? Now this is your classic appearance of cardiogenic shock, and you have hypotension and hypoperfusion indicating that they are now needing an inotrope or mechanical circulatory support. The lactate is now greater than or equal to 2, and keep in mind, and this is one of the most important things to know, is that this may be normal in chronic heart failure patients. You'll see the hemodynamics when you drop in that beautiful swan that we love so much. The cardiac index is now less than 2.2. The wedge is elevated, indicating elevated right-sided filling pressures, and you also can have some biventricular failure with indications of right heart failure by hemodynamics, which we'll go into later. When you go to stage D, now this patient is obviously deteriorating. There is no question about their shock, and you have what you have in stage C, but deteriorating. And you now here highlighted in orange, you see the updated guideline that the lactate is indeed rising and is not improving, and now they're requiring multiple pressors or escalating of pressor doses, which is another update from Wednesday, or they need mechanical circulatory support in order to survive. And of course, E for extremis, this is as we unfortunately like to say, they're trying to die. Everything we're doing is not working. It is very, very difficult. They may require ECMO, have ongoing CPR, but this is extensive, it's worsening. And added to this is the lactate greater than 8, now added recently on Wednesday. So this is now in pyramid form, and I do ask for your forgiveness for any formatting issues because I am a Mac person, even though I don't get sponsored by the company, which I wouldn't mind if anyone's here from them. But you'll see stage E here is extremis, and it gives you a brief overview and approximately the same things that you want to look for. This is extremely important because we as physicians are trained to see maybe late C and then D, and then throw our hands in the air for E because we didn't see them starting at A. We didn't recognize it. So it's very important for us to identify these stages. So how does this translate over to heart failure? Well, we have Intermacs, and Intermacs is kind of similar in that we pick up at stage 3B. I guess they did not have a barostim, or else that would have been fantastic. And then if they're Intermac 7, they're kind of in NYHA class 3B. Then you start to see them slide, so they're walking and wounded. Then they become housebound, frequent flyer. We all know the names on the back of our hand. Stable, dependent now, sliding fast, crash and burn, and we can't even assign a number to the stage for when they're dying and have multi-organ failure because it is that poor. But what do these stages mean? In heart failure, in 5 to 7 means they have months to years of survival, which is not long at all. And the bad benefit in there, which we'll talk a little bit about advanced therapies, but not as much, it's not really established. However, when you hit stages 3 to 4, now they have weeks to months. This is very important to recognize so that we can intervene before it becomes too late. And having a durable LVAD, left ventricular assist device here, does show benefit. Going down to stages 1 and 2 where they're sliding fast, crash and burn, and you can kind of correlate this back to the SCAI stages, you'll see that now they have hours to weeks, and once they have multi-organ failure, it says hours to days. Personally, I don't believe that, and I doubt anybody else on our panel does. It's really just hours. And then you really have to figure out what to do really fast and see if there are any options. So what happens? Well, acute this study did show some decrease, but I bet if we had sub-selected and a decline in acute, in more, a bit about advanced therapies, but not as much, it's not really established. However, when you hit stages 3 to 4, now they have weeks to months. This is very important to recognize so that we can intervene before it becomes too late. And having a durable LVAD, left ventricular assist device here, does show benefit. Going down to stages 1 and 2 where they're sliding fast, crash and burn, and you can kind of correlate this back to the SCAI stages, you'll see that now they have hours to weeks, and once they have multi-organ failure, it says hours to days. Personally, I don't believe that, and I doubt anybody else on our panel does. It's really just hours. And then you really have to figure out what to do really fast and see if there are any options. So what happens with cardiogenic shock, specifically with respect to mortality? It's the leading cause of in-hospital mortality in patients with acute MI, and there's surprisingly been a decline in acute in-hospital mortality. And the question is why? Well, if you look at acute MI, the decline was 42% to 34%. That's because upstairs in the beautiful other sessions, they have extreme advances with such intelligent people who are doing interventional cardiology. There's early revascularization, and then there's proliferation of cath labs everywhere, which is a beautiful thing. In non-acute MI, remember we saw that the incidence, the mortality, everything was rising there. This study did show some decrease, but I bet if we had sub-selected some heart failure, it may not necessarily be as robust. But the importance of early diagnosis has helped. Advances in critical care management, which we have seen across the United States and Europe, as well as proliferation of cardiac ICUs. Overall mortality with cardiogenic shock is approximately 30 to 50% still. So why is mortality better in cardiogenic shock with MI versus heart failure? Is a very important distinction. Well, acute MI is temporal, it's acute. There's a sudden onset of an event. This is reversible with intervention. People know, hey, there's a heart attack, get them immediately to the lab, let's do something about it. It's very easily recognized. You have EKGs, you have troponins. It's very frequent, but it's extremely well managed. It's treated like an emergency, and of course the advances in PCI. There's a plethora of skilled interventionalists. Most of them are upstairs, so luckily UM is not that far away from here. There's immediate involvement of interventionalists. They get called literally from the ambulance in some hospitals, at least my old hospitals like that, there's no delay in mechanical circulatory support. So if they need a balloon pump, they're in cardiogenic shock on the table or an Impella, right then and there, they get exactly what they need, which is wonderful for the patient. What about heart failure? Well, heart failure can present as cardiogenic shock, but how? It can be progressive with disease, it could be acute on chronic heart failure, or it could just be sudden heart failure and down they go. And I'm going to present some cases to support this. It's frequent, but it's not always diagnosed. There's limited biomarkers, BNP, which is limited in interpretability. And then, to be honest with you, I probably did not do very well at recognizing JVD until I was a heart failure fellow, despite working under very esteemed attendings in cardiology fellowship. Clear chest x-ray, got this text from a lovely attending primary care yesterday, but the chest x-ray is clear, the patient's doing better, but their ear is flicking and they have JVD so extensively high, and that's why I please prefer IV diuretics. And commonly, if there is something there, it's pneumonia. Although one of my favorite ways that people present is, oh, I have stomach pain. You don't have stomach pain, but guess what? Your gallbladder is going to be removed, and you really had cardiogenic shock the whole time, and I have a list of patients with that. Would love to do a trial in case retrospective analysis. That'd be fascinating. It's very frequent, but it's treated like a standard admission, not like the chest pain. Chest pain is an emergent, easily recognized. Let's jump on it, but not heart failure. There's limited number of heart failure specialists, and there's a delay in involvement of heart failure specialists. We're not going to get called from the ambulance, and we're not going to get called from the ER. To be honest with you, we may not get called at all, and general cardiologists graciously may be helping in advance in the beginning stages. So let's talk about what happens with progression of heart failure. I alluded to this in the beginning of the last slide. And with cancer, for example, 70% of loss of function occurs in the last 3 to 4 months, so this being time, this being quality of life. And this is the expected course in the majority of cancers. Well, heart failure is very different, and it's very tricky, and it's not the same as that. So initially you could have a drop-off, we could improve you, and then you go along, and then all of a sudden something happens, you go down, you come back, and then this could be the progression until you hit stage D. But that's not how it always happens at all. In fact, and I hope you like my colors here because go Hurricanes, at the onset of disease, here you can either present as I just showed you here in the maroon color, or you can present here the way a shortened course of this where the time is much less and in the yellow. But what if you just present, all of a sudden you're going about your business, you're shopping, buying new shoes, maybe a new top, and then boom, down you go. And that is very important because there is no identifiable, predictable, there is no mirror ball for us, crystal ball for us to be able to tell where does this happen. So why, again, is mortality better in cardiogenic shock and MI versus heart failure? There's so many different paths, which I just showed you. It's very difficult to assess where in the spectrum they are, which spectrum there are, because it's so individualized. It's very easy to miss that window because you don't know where you are in their personal progressive course. With chronic heart failure, it's even a little bit worse because they appear stable. They come into the office, I feel great, I feel fine, but they're not doing grocery shopping anymore, they're not walking as far, they're not going with their kids to the park, and you really don't know until you do something objective like a 6-minute walk test, etc., or a CPET. And with acute on chronic, again, you don't know if this is the episode that sends them into shock or if this is the episode that you can recover them from. So because it progresses different in every patient, you cannot assume. It's also not clear and reversible. There are 6 main triggers for heart failure, and I educate all my patients on these 6 triggers. And you can find them in the guidelines, but I'll touch briefly about them here. If they're volume overloaded and it's just a short period of time frame, you can reverse this. Take the stress off the heart. I like to describe it as people, because it's a running joke that men like to carry every grocery bag into the house at the same time. Well, you carry all the grocery bags and then you want to hand him something else. Well, you can't hand him anything else because all his arms are filled with grocery bags. Well, what you do is you relieve some of the stress, take off some of the grocery bags, which is the volume, and now he can take on something else. You have to relieve the stress of the heart, but that means it could be reversible. But if he holds it for much longer, it's not going to be reversible. Same thing with pausing medications. If you pause medications, if you don't do it too long, you can recover them maybe, but if it's for longer or the heart was living on that last crutch, you kick out the crutch from the heart goes down. So it's not clear. Progression to end stage, it's limited, depends on the contractility, and it may not be reversible, and then it is, you do get presented with cardiogenic shock. The incidence is also higher, briefly touching, even though guideline-directed medical therapy is advancing, as we've heard very extensively. The problem becomes is there's still a challenge to implement them. I remember being a fellow under Dr. Josh Hare, and he said, no, you push them until you can't go any higher on the doses. He didn't say there was a goal map. He said you push them until they get dizzy, then you back off slightly. And I still remember that day in February, many years ago, and I never forgot it. And it's very true, and it allows for recovery, but not everyone does that. People walk into the office, my blood pressure's great. Give me the numbers, please. So it's recognition and management is variable by cause. Now we're seeing a lot of COVID myocarditis, not COVID vaccine myocarditis. In case anyone is curious, please share with your friends. So because heart failure, the presentation, the course, the progression, the prognosis, the intervention, everything is unclear. It's individualized to the patient because the incidence is higher, the mortality is higher. It requires that cardiogenic shock with heart failure needs to be assessed by hemodynamics, and let's talk about it. So originally Lynn Stevenson, now at Vanderbilt, previously at Brigham, she had published this beautiful perfusion versus congestion diagram, which I still love to teach to the University of Miami medical students today. But we've now updated it with what Sky has to say about what we do. And basically, you'll see that this is all somewhat of a continuum of cardiogenic shock, where here, how perfused are you? Are your feet warm? Are they cold? Is your heart giving your body what it needs? Here, how congested are you? What's your volume status? Are you wet? Are you dry? So if you're dry, you're warm, you have a good cardiac output, cardiac index, your blood pressure should be relatively controlled, and of course your markers of volume status are normal. So you just give them maintenance therapy, like Dr. Grisette had already mentioned. Well, what if you're wet but you're still perfusing? This is a mixed cardiogenic shock picture per Sky. You could still have a borderline low cardiac index, a borderline low or normal SVR, but a high wedge indicating high volume. So you give them IV diuretics. You can give them vasodilators like nitroprusside. Very important to know this because there's a distinction between what we classically want to give people and what we should be giving them. So it's very important to note this category. What about if they're dry and cold? These are patients that are walking around on inotropes, well maybe not walking so much, but they are in shock, but they are not overloaded. But wet and cold is the crashing patient you have in the hospital, severely volume overloaded. This is your classic cardiogenic shock. Inotropes, IV diuretics, vasodilators, and possibly mechanical circulatory support, temporary or otherwise. So let's talk about the diagnosis. I just mentioned briefly in the previous section that you have a reduction in your systolic blood pressure. You have tissue hyperperfusion. It's really difficult to distinguish cardiogenic shock from other forms of shock without invasive hemodynamics, and we've had a case very fun this week that unfortunately I had to cath a couple of times and just decided finally let me leave this swan in. Because it was that difficult. But invasive hemodynamics, they're absolutely essential in order to measure intracardiac pressures and cardiac output. By definition, this is, yes, heart failure, clinical syndrome, fine. Throw that out the window for a minute because the true definition of heart failure is acute exacerbation of heart failure is elevated filling pressures. 3 words for the rest of your life. Never forget it. Sing it in your sleep. Never forget it. You'll pass your boards. Use of the pulmonary artery catheter is associated with lower mortality in cardiogenic shock patients, and I'm going to go through some trials towards the end. So what are the indications? I've combined the American Heart Association and the European Critical Care Medical Guidelines, and it's very simple. If they're in respiratory distress, if impaired systemic perfusion, and the clinical assessment is inadequate, it is recommended level 1 for American Heart Association and level 1 for European to put in a swan. It is absolutely recommended. If they have persistent symptoms, they're not responding to initial therapy, or their hemodynamics are uncertain, it is still a 2A by the American College of Cardiology, and actually it's a class 1 by European to put in a swan. It's not recommended for routine use, but we knew that despite what happened in the ESCAPE trial, which we'll also talk about. And sequential hemodynamics are now are recommended by Europe, and if it's refractory shock, and especially if it's RV dysfunction, you need hemodynamics, and if it's severe shock with ARDS in the critical care setting, obviously, we are recommended to put in a swan. Contraindications, briefly, left bundle branch is a relative contraindication because you could accidentally result in complete heart block. That was contraindications. Complications, same as when you put in a central line, pneumothorax, air embolus. Please don't ever overwedge. You can be at risk for causing a nidus for thromboembolism. So that's things to consider when you're putting this in. It is not benign, but caution can be taken. So let's talk about some cases. And this is the exciting part now. So we had a 49-year-old man come in to the University of Miami, and he had history of a surgical aortic valve replacement done in 2013, and it was because he had a bicuspid aortic valve. And he came in with positive troponins, but barely positive. It was right under 1, and so he wasn't immediately taken to the cath lab. He had an echocardiogram, which I'll show you on the next slide, but basically there were multiple wall motion abnormalities. His ejection fraction was newly reduced. He had elevated filling pressures, as indicated there. Biventricular failure, the right side was also down, and his prosthetic aortic valve was critically stenosed, as you see by the numbers there, a nod to everyone upstairs. So I hope this plays, and it's on a loop, and we have 3 echo images here, and you'll see that the patient is in severe biventricular failure with volume overload. So you see here in the apical forward chamber that you can see this poor contractility of the left side, and then the right side is somewhat down. And then the right side, you can see it here in the peristernal long axis. And now here looking at the inferior vena cava through the subcostal view, it's dilated without inspiratory collapse. And again, this prosthetic valve, as I already mentioned, you can see it's not opening. Let me give you some more images. If you see right in the center there, it's not opening. And so it's severe aortic stenosis. So we were consulted on the case, and so we ended up coming on board with the general cardiologist and the interventional cardiology team, which we came upon later, but before we saw him, he was taken to the cath lab, a left heart cath was done, new diagnosis of coronary artery disease as indicated here, and these were his hemodynamics. The right atrial pressure was greater than 5, so greater than 10, and it was 15. He was overloaded on the right side. His wedge was 33, overloaded with volume on the left side, and his cardiac index by FIC was 1.86 on no support, so he was absolutely in cardiogenic shock. He had elevated right and left-sided filling pressures. He was this person in orange, so our fear is right here. He did not take the standard progression, instead he was here. And so our decision at this point is, what do we do? When we see someone that is taking this course and we don't know that it's going to come right back up, what do we do as far as advanced heart failure therapies? Is this something we can recover? Is there an intervention that's an option? So here I bring back the classic, that hemodynamic profile in heart failure, and you see he was wet, cold, classic cardiogenic shock. So he had severe symptomatic aortic stenosis, triple vessel disease, and you could not talk to him without watching his rhythm because it was in VT, maybe interrupted with a few beats of sinus. And he was in cardiogenic shock, he was confused, he was yellow, his LFTs were up, his creatinine was bothered, he was in acutely decompensated biventricular failure with elevated JVT, everything was quite obvious. So we got consulted the next day, 7 days after he was admitted. And at this point, we decided, hey, he's in shock, let's transfer him to the ICU, we are concerned. Unfortunately, his diuretic therapy was de-escalated based on clinical exam, he was hypotensive, but we were still concerned about worsening shock. So at my first opportunity, I brought him back to the cath lab, and we found out not only was he still in shock, he was worse. The right side deteriorated even further, which I'm sure the ventricular tachycardia didn't help. The pulmonary capillary wedge pressure was still elevated. He did not gain any benefit from diuresis for the left side, and this was his index. Friendly tip, anytime you see a 0 before a decimal, it's just not something you want to be too nonchalant about, although I nonchalantly asked the wonderful Dr. Eddie De Marchena, would you so kindly please put in a balloon pump with the interventional team, which they kindly did. So with the balloon pump, his index did improve to 2.2. We were able to appropriately diurese him, and his NSVT did decrease. It's NSVT, but it's not really, because like I said, it was just a few beats of sinus in between. So management, of course, because of the pannus of the previous valve, TAVR was discussed and not necessarily the best for him. we decided to go for a minimally invasive surgical aortic valve replacement. We felt that the bypass time would have been a little bit too long, and so he was discharged home with physical therapy. He came back with the esteemed Dr. Carlos Alfonso, and he was revascularized as indicated there, and he is supposed to be following up with advanced heart failure. So the benefits of hemodynamics in case 1 shows us it prevented further worsening of shock once we did initiate hemodynamic monitoring. It allowed for treatment of hypervolemia. It'll stabilize the patient prior to surgery. And altogether, because he actually didn't have an option until we stabilized him, the surgeon was saying no. So that was another part of the delay of care, and I don't blame him because he would have had a perioperative mortality then. And so altogether, the invasive hemodynamics reduced morbidity and improved survival in this patient. So let's talk about case 2, which is also quite fascinating. 50-year-old male. He had shortness of breath and exertion back in August of 2019, came in with heart failure to another hospital, had a defibrillator placed, then had a stress ulcer, was admitted for 3 weeks. This was complicated by multiple pulmonary emboli. Turned out he had HIT, which was a new diagnosis for him. He got an IVC filter placed, went to rehab. But then he was brought back to the hospital because he was in hypoxic respiratory failure with cardiogenic shock. He got shocked a couple of times due to actual VT, and he was initiated on milrinone at a low dose and transferred to Jackson. At that point, he deteriorated. We put in an intra-aortic balloon pump, had to increase his milrinone to 0.75, and he was also on dobutamine. So he required extreme escalation of therapy. So this is a guy that was the SCI guidelines of stage D for cardiogenic shock running into stage E. So hopefully this plays, and you can see the large pleural effusion here on the left. I'm sorry, it's not playing, but he is in severe biventricular failure. You see that the right ventricle is participating just as terribly as the left. There's a funny little guy here waving to you. Please note that you're going to see him on the next slide. Oh, that one starts late. Okay, so you're going to see here, it's kind of cute. He's waving to you, and he's going in and out of he's a mobile and fixed massive left atrial thrombus. So this was his course in orange. He didn't get as much time as whoever this lovely gentleman or woman was, and he declined in a matter of just a few months and went down quite fast, requiring 2 inotropes and mechanical circulatory support, and still was not stable. So what do we do then? The patient is sick. He needs advanced heart failure therapies. Well, advanced heart failure therapies can be given unless there's a PVR, pulmonary vascular resistance, of greater than or equal to 3. This has been shown in multiple studies that it predicts poor outcomes. And echo, despite it being so fascinating and wonderful, in 1997 they had a study which showed 25 patients where the invasive correlated to non-invasive, and then another study in 2008 with 67 patients. But here they find that they only looked at pulmonary artery. They didn't look at all these extra numbers. With an LVAD, right heart failure, which he had severe right heart failure, very well known to cause LVAD malfunction. Patients do not do well with it. It's high morbidity, high mortality, extremely high when there's right heart failure and you try to put in an LVAD. Okay, so what about the guy who had this massive clot that was waving to you on echo? And so there was a study that was recently published in December of 2021. They looked at 525 patients in the same center with a HeartMate 2 or a HeartMate 3, and they, over a 10-year period, retrospective analysis, and they found that thrombus extraction, increased bypass time, and independent presence of this thrombus caused increased morbidity and mortality. And this was shown at 6 months and at 1 year. So now what do we do? Well, here's the guy's echo. In a brave way, with the assistance of another esteemed cardiologist, Dr. Joseph Bauerlein, I happily went into the cath lab because he had an echo done, and they tried to do hemodynamics with the echo, but his PVR was 3.42. So that takes away heart transplant. That takes away LVAD because he has right heart failure and a clot with the high mortality. So what do we do? Well, I took a pediatric swan, and I advanced it into the right atrium, swimming by that friendly waiver, and we were able to get a PVR, and it was 1.29. So in fact, it did not correlate. It not only didn't correlate, but it also now offered him options he would not have had if he had an echo. So he was listed for a status 2 for heart transplant. On March 3rd, he was transplanted within a few weeks, discharged on the 9th quite quickly. He did have one episode of 2-hour rejection, but outside of that, I saw him in clinic a few weeks ago. He's doing really well and living a life that he would not have otherwise had. So the benefits of hemodynamics in him is the same thing. If we had followed this at the echo, if we had followed non-invasive hemodynamics, it would have precluded him from transplant. Because he had right heart failure and intracardiac thrombus, the LVAD would have had a higher morbidity and mortality. So invasive hemodynamics in this gentleman actually saved his life and helped him to have one. So let's discuss. So when you're looking at the inpatient setting with heart failure, the basic information that you want to get is volume status, perfusion status, and it's going to directly impact your management and prognosis. We constantly say, do not do something unless it's going to change management or prognosis. So echo, you can look at the volume status. You look at the IVC. If it's dilated, then you say, okay, high volume, high radial pressure. You can calculate the cardiac output by using a bunch of different equations. However, this IVC dilation, it can be high in athletes. There's alternative reasons for that. It does not indicate whether or not there's left-sided heart failure. It doesn't always correlate. Cardiac output, the calculation of it is very difficult to do. You have to have extremely good views, and then if you have any valvulopathies, it's going to interfere with your numbers. And if they're critically ill, you're definitely getting poor windows. It's not like you're going to move a vented patient. You have very difficult access of getting pulse wave Doppler angles. And the caveat is, this is published, and I did not present it in this lecture, but mechanical ventilation, when they're breathing in, when they're breathing out, there's been multiple publications about this, it completely throws off your numbers. So the more disadvantages, you have poor assessment of right heart because of the windows, and that's shown, but if you use hemodynamics, you can go ahead and have beautiful numbers where you can get true definition of right heart failure. So the advantages is non-invasive, it's quick, but it should be considered an adjunct, not ever to be confused with how you assess hemodynamics. The pulmonary artery catheter is still the way to go. Well, I get this question a lot. Why can't we just use a PICC line? Why can't we just check the superior vena cava, oxygen saturation, correlate it? Why can't we just transduce it to CVP? Well, I'll tell you why. And I am going to skip just a few slides ahead just for the sake of time, but there is an up to 6% variability in the PA saturation versus what you get from the superior vena cava. In fact, in the worst case scenario, it's actually up to 20%, which I didn't put the graph here, but it is there. So they looked at normal oxygen, when there's hemorrhage, when you resuscitate with 7.5% volume. This was done in animal studies, so similar to what Dr. Hare also participates in. Hypoxia, and then back to normoxia, and then hyperoxia and hemorrhage again. And you see the difference here in the variability between the measurements. It is at least 5 to 6% consistently, and you don't know which one's higher, which one's lower. There's no standard correlation. Well, what about if you just use an A line? We all know that pulsatility, the pulse pressure index, tells us the contractility because it indicates what the stroke volume is, which therefore falls into cardiac output when you multiply times heart rate. And that's a beautiful thing, but there's no information on volume or perfusion, and you can get catheter-associated arterial thrombi, which is a horrible complication. So what you're supposed to do is you're supposed to use this complementary data. Now, quickly to close, I'd just like to talk about a few trials. The support trial was in 1996, and in 1996, this is the trial that everyone takes this information and then they run with it. It was 35 ICU patients over 5 years in 5 U.S. teaching hospitals, and it was an estimated these patients already had to have an estimated 6-month mortality of 50%. They used a propensity score, bless you, and adjusted for treatment selection bias. They had an increased 30-day mortality with right heart cath versus without the right heart cath. I'm going to come back to that. The mean length of stay was similar in the right heart cath versus without the right heart cath, which doesn't make sense if 50% died at 30 days, but take that and run with it. The important point here is look at their disease categories that they put these swans in. Respiratory failure, COPD, cirrhosis, non-traumatic coma, colon cancer with metastasis to the liver, non-small cell cancer. To be honest with you, I've not been asked maybe once in the last 4 years at University of Miami to put in a swan on any of those patients, and it was just to see if they were a candidate for transplant for liver. Of the 9 disease categories, only one was cardiac specific. They do not go into the subgroup analysis at all. There was a mix of medical and surgical patients. Not all these patients would have even been given a pulmonary artery catheter. These were done at teaching hospitals. There's more procedural complications, except of course at University of Miami. This is prospective, not randomized, and there was a non-uniform approach that they saw very clearly. And since 1989, when they started this, there's been many advancements. So let's talk about the ESCAPE trial, which is thoroughly quoted, however, maybe not correctly. So in this trial, they had 433 patients at 26 sites with heart failure that are considered to be heart failure sites over North America over 4 years. And they had to look at, okay, basically they needed hospitalization for heart failure symptoms. But they excluded people. Their creatinine could not be greater than 3.5. They could have never had an inotrope, never had a history of using an inotrope. And that's fascinating to me. So these are strictly early stage C patients. Their primary endpoint was days alive out of the hospital during the first 6 months, and their secondary endpoint, they actually followed up with them, and basically looked at their quality of life. And the therapy in the group was to look at the therapy in both groups. It actually did reduce the symptoms of volume overload, JVD, and edema. And their conclusion was there was no difference in the volume overload reduction, length of hospitalization, and mortality with or without the pulmonary artery catheters. But there's a trick to that. If you read the fine print, it says that they wanted patients that were sick enough that would make it reasonable to use a pulmonary artery catheter, but not so sick that they could cross over and end up getting a pulmonary artery catheter. So even more problem with their selection. They chose stable stage C patients with just a basic run-of-the-mill early stage C acute exacerbation. And they excluded the shock, the patients with history of shock or inotropes. They didn't discuss lactate, which, as you know from the SCI guidelines, both old and new, is very important for patients, and we can miss shock. Not just that, lactate can be normal in chronic heart failure. So the clinicians followed the guidelines for treatment for heart failure with respect to IV diuretics and vasodilators, but there was no uniform strategy when it came to hemodynamics. They also used the use of inotropes was, in quotes, consistently and explicitly discouraged. So you see shock, you do nothing about it. Just remember that. There was also a crossover still, because the physicians were like, this is ridiculous, a crossover of the use of pulmonary artery catheters at a large percent that completely was not included in their statistical analysis. They did call the patients later and say, how's your quality of life? And they found that the patients that had the pulmonary artery catheter were treated to goal euvolemia, whereas the people who did not were not treated to goal euvolemia. And then, it does tell you that advanced heart failure sites, they're supposed to have superior management, and they're expected to have better outcome. But the true conclusion of this trial is already what we know from the guidelines. It already tells you what I listed above, which is well established, which is that you're not supposed to put it in routinely, not for people without shock in stage C. This has nothing to do with shock, nothing to do with stage D, nothing to do with stage C sliding to D, and advanced heart failure. So ESCAPE is not applicable to pulmonary artery catheters. And now if we look at some of these registries, we find that in the IQ database here, that no hemodynamic monitoring resulted in worse outcome as compared to hemodynamic monitoring, and also when using Impella, same principle was seen. And this is with cardiogenic shock with acute MI. And finally, my last slide, and I am proud to say that this was published by University of Miami. There was looking at the 10-year in-hospital mortality trend, and the number that they used was almost 10 million people. And what we have is looking at this registry, that cardiogenic shock with the pulmonary artery catheter resulted in reduced mortality. Funny and interesting here, but wait a minute, what about heart failure? There was more mortality, with the pulmonary artery catheter. But we just talked about, for multiple slides, people don't recognize it, people don't intervene, and then people go and follow the ESCAPE trial, and it tells you to go into the wrong direction. And so and then plus, heart failure patients are a lot sicker. You don't know where in their disease spectrum, in their disease progression they are, because it's individual. And so you cannot actually relate that without knowing those factors. So until that gets uniform, until that gets improved, you really can't look at mortality. So, approach to cardiogenic shock and conclusion, you need to identify it early treatment, be aggressive, be a team member. This is a team approach. ICU, heart failure, interventional. Everyone needs to be on the team together here. Continuous hemodynamic monitoring has numerous indications. It provides extensive information. It improves survival in the right population. I hope I've convinced you. Thank you.